I had my first miscarriage at like 34. And when you have your first miscarriage, they really don't chalk it up to anything. They're like, it happens. We really only start investigating after a second miscarriage.
I remember specifically the first time I experienced really severe pain related to this. It was in 2015. I had to go to the emergency room. Even then, I was doubtful. I'm like, it's just period pain. Why do I need to go to the hospital? And when I realized I couldn't even breathe of how painful it was.
So everything was going fine, and then I came in for my first appointment, and I started spotting, and they, weren't really concerned. It happens in early pregnancy, but for me, it's a trigger. And so I went in and just checked, but they did not give me like an ultrasound. They were like, no, we'll just wait. You're close to it. And then they did blood work. Unfortunately, my HCG was dropping and went down, and I was having another miscarriage. So at that point, they recommended that I probably be referred to UConn or to CARS, the Center for Advanced Reproductive Services, just to see if there's anything going on.
And 5 years of that, going back and forth almost every month in the ER, complaining of pain.
They discovered during my saline uterine test that looked like I had a chocolate cyst, which would indicate that I had an endometrioma, which is endometriosis, and kind of was told, yeah, okay, like it was brushed off to me, even though my brain was kind of like shattered and like, oh my God, this is a big deal.
Elise had several projects, mainly on breast cancer, but then endometriosis samples slowly started coming in, and we started asking questions, and she became very passionate about it. She's very passionate about her work, so when she brings somebody in to work with her, you become passionate about the project as well.
Elise Courtois is a researcher at the Jackson Laboratory. She is using the newest technologies to study many human diseases, including Kristen's and Martine's disease, endometriosis.
So endometriosis is a very common disease. It impacts 1 out of 10 individuals born with a uterus. It is defined by the growth of tissue that resemble the inner lining of a uterus, the endometrium, outside of a uterine cavity. Those growths are termed lesions, and they usually invade the body, most commonly within the pelvic area, but they can also be found elsewhere, so in organs as distant from the uterus, such as the lung. So, and those lesions trigger very serious symptoms that are not very well characterized because we don't know much about the biology and the reason why those lesions established at first. Endometriosis has been known for about a century. Nevertheless, it's a disease that has not been really well addressed at the funding level, and that has made it hard to get a very deep understanding of the pathophysiology of this disease. We have, unfortunately, not many ways to diagnose endometriosis unless using invasive approaches such as surgery to visually confirm the presence of those lesions. That is a big hurdle when you want to understand a disease, because you don't really know how many people are affected by this disease and what is the natural progression or the cause of this disease.
Courtois has formed a collaboration with UConn Health's Dr. Danielle Luciano to better understand real patient needs.
Within our division, we do about 300 surgeries a year, but some of our patients do not need surgery, which is fantastic. We can sometimes treat them with medical management alone. I would say on average, I see about 4 to 5 new patients a day. Endometriosis is really difficult to see until it becomes big enough to see by ultrasound, and at that point it's often advanced stage. So we've based it a lot on history and physical exam findings, probably almost entirely on history. The only way to diagnose it for sure is to do a laparoscopy, remove the tissue, send it to pathology, and have the pathologist tell us that's what it is. That's still technically the gold standard.
Endometriosis is often misdiagnosed or missed entirely. There is still no known test or biomarker to prove a patient has endometriosis.
It wasn't the same time every month, but I had a period, like one day where it was like I was on all fours on the ground and like could not find a position or anything to relieve my pain. You know, when I talked to Dr. Luciano, when I first met with her, I said to her, you know, I started having weird symptoms that I would have never thought was related to this, you know, in 2014. You know, was this, for example, I started having a lot of like stomach issues and gut issues. I had like eczema on my hands, all these things that I knew were related, but I didn't know where they were stemming from. And I had asked her, you know, is this related to endometriosis? Was I misdiagnosed? And she was like, yeah, this was probably the start for you.
Courtois' research compares tissues that form the lesions that cause endometriosis symptoms. These lesions are different from patient to patient. While they can be removed surgically, lesions often return. Courtois' efforts will help identify a way to diagnose and treat a patient without surgery.
There's a lot of things we still don't know about endometriosis. For example, we have mostly theories to explain its origin. Those theories can make sense for some of the clinical presentation and surgical presentation of a disease, but do not really enable to understand endometriosis in its variety. We diagnose at a later stage of a disease, and we do not know how it really arises. That makes it very difficult to understand what is the first trigger for this disease to happen. We work very closely to the clinical setup with my colleague Daniel Luciano, and the way we try to understand the disease is really to collect tissues from surgeries from patients that are undergoing lesion excision, and to try to, using single-cell technologies, spatial technologies, to understand how the disease impacts the endometrium of a patient, how the lesions differ between different locations and different stages of severity of a disease, and also to understand at the systemic level how endometriosis impacts the whole body.
Part of the reason why we know so little about endometriosis is due to the historical lack of support and funding for women's health issues. Here in Farmington, Connecticut, the tides are changing. Courtois and Luciano have joined forces with Connecticut State Representative Jillian Gilchrist and the Connecticut Endometriosis Working Group to spread awareness about endometriosis and expand access to care. Together, they have established a biorepository, the first of its kind, to collect, catalog, and store real patient samples from a diverse population.
There was very few information for me to grasp at and understand what was happening to me in my body.
You know, I feel frustrated and angry that I didn't have more information and didn't advocate for myself more. And if there's anything I can do to try to raise awareness about this, I'm gonna do it.
I'm hoping we can have a cross-state collaborative efforts to have a wider pool of samples and see how this condition affects so many people.
You know, when I've done research with JAX and I have to consent these patients, I've never once had a patient say to me, no, you can't have my tissue. I don't want anybody to find out how to cure endo. Like, we're all in this together as women.
So this is really a unique opportunity that we have at JAX, because we're really partnering with this endometriosis reference center. We really have a deep understanding of what the history of those patients and what the condition and the surgical presentation of those lesions are, and we can really align that with what we see at the single cell and spatial level.
I think we as women are the ones that have to be proactive for ourselves and for our daughters and for our daughters' daughters.